Our next speaker will be Dr. Madhav Karunakar from Carolinas Medical Center in Charlotte, who's going to present, I think, a very interesting case with some soft tissue issues that really play an important role in the treatment and things that have been many questions asked about already. So, Madhav, I'll turn it over to you.
Okay, so this is a 17-year-old female who was involved in a motor vehicle accident. At her time of injury, she had an open femur fracture, the pelvic fracture that you see here, and she was subsequently transferred on post-injury day 3 to our facility for management of the pelvis. I think anytime that you are initially evaluating a patient, you need to take a look at the films and take a step back, and this is clearly a lateral compression type injury, and we heard earlier in the lectures about associated injuries, including head injuries, abdominal injuries. Fortunately, this patient didn't have either of those. When she presented, she had some hemodynamic instability, and you can see a coil where she had a embolization of the obturator artery. And while not uncommon, you can have injuries to the vessels in a lateral compression type injury. You can see she's in traction for when she was transferred for her pelvis. Here's some further imaging, and when we look at this imaging, try to be systematic in your evaluation. We start first with the right SI joint. It doesn't look too bad on the images. And then we move over to the left side, and on the left side we can see the fracture of the iliac wing that extends up to the SI joint, has a segmental component to it. The rami fractures in the front on the left side, a relatively simple fracture of the superior and inferior ramus, and on the right side, a very comminuted fracture of the parasymphyseal region. When we look at the anatomy of the sacrum, there doesn't appear to be dysmorphism and no additional sacral fractures. You can also notice that the hip looks a little bit distracted on the left side, so the patient is in traction, and this is how she was transferred. So then we go to the CT imaging. In similar fashion, you can see the comminuted anterior ring and the left pubic root rami fracture. See the iliac wing fracture, and you can see here where I stopped it that the fracture really is a little bit anterior to the SI joint. So this is important in your operative consideration that iliocecal screw by itself will probably not be adequate fixation for this fracture, and that you would either need to address the segmental component or have some sort of fixation from the inferior spine into the posterior fragment. So our initial plan was to take her to the operating room and address the posterior ring, starting with the left side, and address the segmental fracture component through an open lateral window, and then examine the right side, because it's not unusual with these bad lateral compression injuries to have an external rotation deformity of the right side, and then follow that by assessing the anterior ring. On the day of surgery, however, she spiked a fever to 105. This is her second hospital day, post-injury day 5, and obviously we were concerned about this. So ordered a CT scan, and you can see on this CT scan that there's an abscess in the labial region, and there also is a retropubic abscess. And then on this image, you can see an abscess in the adductor region. So she had adductor, labial, and retropubic abscesses, and this obviously was concerning and changed our plan. If you look at the initial CT that I showed you from when she was transferred, you can actually see air in the area around the pubic rami and in the labial region. So it's likely that this patient had an open pelvic fracture that was not identified at the time of injury. And it turns out when we took her to the operating room that she did have injury in the vaginal wall. I would like to take a minute to just discuss the discuss open pelvic fractures. This is a little bit unusual in this circumstance in that it was identified in a delayed fashion. I think one of the important things is to use all the information that you have on your initial evaluation of the patient. So clearly you can see air in the soft tissues. That should have been a warning sign that there's a risk of open fracture. Having a complete examination, including a vaginal exam and a rectal exam, is critical when you have these significantly displaced pelvic fractures. When you identify an open fracture, this is, I think it's very important to have coordination with your care with the general surgeons and potentially with the gynecologist. And in my experience, most of your colleagues will not have a lot of experience with these injuries. So they're looking for you for guidance on what to do. And I would recommend very strongly, in addition to coordination of care, being very aggressive about your initial management. And the initial management should be a very thorough debridement and trying to close when possible the wounds. If there's a injury that goes into the area by the rectum or in the perineal region, to have the conversation with the general surgeon about diverting colostomy. So in this case, we took the patient to the OR with the help of the gynecologist and went with for an IND of the thigh, the adductor, and the labial abscesses. And we started first with looking at the vaginal region and then the thigh, and then performed a symphyseal, phanastile type of approach to decompress the retroperineal, the retropubic abscess. And during that exposure, identified a extraperitoneal bladder rupture. So at that point, we consulted urology, and urology came in and did a primary repair of the extraperitoneal bladder rupture. So this gives us another opportunity to discuss associated injuries. Bladder ruptures probably occur about 10% of the time in pelvic fractures. Extraperitoneal bladder ruptures are more common than intraperitoneal bladder ruptures. From a urologic standpoint, if a catheter has been passed, a Foley catheter has been passed, urologists frequently will say that they don't need to do anything with these injuries. However, if you're considering fixation of the anterior ring, it's important to coordinate with them, and at the time of your anterior fixation, they can often repair the extraperitoneal bladder rupture, and then you can proceed with your operation. A little more complicated situation would be if you had a urethral injury or a suprapubic tube, and in that case, again, it's critical to coordinate with the urologist in terms of management of the suprapubic tube. In general, we try to ask for the suprapubic tube to be moved off of the midline, off to a side somewhere, and as proximal as possible. It is possible at times for them to pass a catheter and then have the suprapubic tube removed or exchanged. But again, it's important to identify these injuries and then also to have good coordination with your consultants. So in this particular case, after we performed the IND of the abscesses and had the bladder repaired, and you can see the drain on the image, the question is, do we need to perform some other fixation, temporizing fixation, such as an external fixator, while we wait for definitive fixation and the timing of definitive fixation? And as I mentioned, the films earlier were demonstrated that the fracture was reasonably well aligned. There's still internal rotation deformity in traction, and appreciating that we were going to come back and do repeated INDs, and elected not to, but I think you could make an argument for supplemental fixation with an external fixator, but I think the traction was helping. So the plan at this point was for repeated INDs. We performed 2 additional INDs, and then to proceed with internal fixation. As I mentioned, the decision for stability on or fixation on the pelvis, the decision was made to move more with the posterior fixation first, as the anterior ring was very comminuted, and it was not felt that this would help that much with reduction. So lateral window was performed, and open reduction was performed with a segmental fracture component with plates and screws, and then a screw was placed down the inferior spine corridor. At that point, there was some external rotation or displacement of the left sacroiliac joint, so iliocerebral screw was placed. And intraoperatively, there was displacement or external rotation of the right hemipelvis. So a right iliosacral screw was subsequently inserted. If you identify the external rotation of the right hemipelvis or the contralateral side in these lateral compression 3 type injuries early, I would typically fix that first to have a stable base, but this was something that was not really identified till we were able to stress the fracture. So after we stabilize the back of the ring, the debate then is what to do with the front of the ring. And as you could see from the initial injuries, the left ramus was relatively simple, could have probably fixed that with the screw. The right ramus was quite comminuted, and it was not certain that screw fixation would be enough. Another option is external fixation, particularly in the face of the prior infection and multiple debridements. That would have been a very reasonable option. However, given that the exposure was already there from the debridements, and I felt that having additional stability would help with the tissue healing of such a large tissue injury, I decided to go ahead with internal fixation. And I think this is a little bit different in the pelvis than you'll hear about later in the course in the acetabulum. In the pelvis, I think you can be a little more aggressive with internal fixation, because if you get an infection, it can often be treated with repeated debridements and salvage of the hardware like we may perform in other parts of the body. However, in the acetabulum, in contrast, if you get an infection in the hip is gone. So while you have to be concerned with the bladder injury and with the prior infection, I think providing stability was a trade-off for that, and that's what we elected to do with in this procedure. And then these are just follow-up films. Patient came back at 5 years for questions about the heterotopic bone that had formed on the lateral side of her femur. You can see that a little bit there. She had a bad open femur fracture. Was doing well from her pelvis, did not have any signs and symptoms of infection, and also had some questions about pregnancy, as she was now in her 20s. And similar to what Dr. Rout already mentioned, we had a discussion that no OB-GYN would allow her to progress through a vaginal delivery. So in summary, I think this case demonstrates a couple of important concepts. First is that you need to thoroughly evaluate your patient and injury. Use all the information that you have, perform a complete physical examination, including the vaginal, perineal, rectal exams. Review all the diagnostic studies. There can often be a lot of information on those studies. Looking at the soft tissue windows, noticing if there is hematoma, blush, hair. Be aware, recognize injury patterns, be aware of associated injuries. In this case, we saw hemorrhage from the obturator vessels. We saw a bladder injury, an open wound. And if you identify these, it's important to manage these injuries aggressively, because I think that's the most predictable way to ensure improved outcomes. Thank you.
Great, thank you, Matt. That's a fascinating case, and as you can imagine, there are multiple questions coming through about plating in the presence of an infection that occurred there. I'll let you answer some. I think you answered most of those in your talk, but you can go through and answer some of those again. Let me just ask you the question that comes up quite regularly, which is, does the presence of a suprapubic catheter prevent you from doing anterior plate fixation? And if you do proceed with that, how do you manage the suprapubic catheter during that surgery? How do you deal with the urologist?
Yeah. So I think a lot of it has to depend with your urologic team. Unfortunately, in our center, we have urology available on a regular basis. So I think, as I mentioned, having a discussion with them in advance about the possibility of removing the tube and passing a catheter, repairing whatever injury, or if they can't, tunneling it away. So in most circumstances, I've moved forward with fixation with urologic assistance in the operating room. But I think it'd really be dependent on how much they feel they could move it or take it out, and what your urologic support is, and how valuable the fixation would be in the front. for your overall construct.
Great, thank you, Matt. There are lots of questions. Yeah, I think it seems like the problem is if you do nothing for fixation and keep putting it off until you think things are perfect, then you end up with a situation where you had the same infection to deal with, but you end up late enough in the process where correcting the pelvic deformity is extremely difficult. And the ones I see that are most complicated are the ones that have these horrible malunions or very delayed reduction and fixations, and had bad tissues and infections that were left open and dealt with in a different way. So I think your technique of being very aggressive with debriding wounds and repairing bladders and moving on with things as quickly as possible and trying to get fixation in is probably the right way to go.